Warm welcome back from the break to the Gender Equality Index Conference for 2021 from our studio in Vilnius. My name is Rasa Tapnin and I hope that you've been enjoying the event so far. Here we will explore the impact of COVID-19 on health and gender equality. The aim of this session is to shed light on the issues that COVID-19 brought to sexual and reproductive health from a gender equality perspective and to offer some solutions to the policymakers. Let me briefly introduce our panelists. We'll have Predrag Fred Matic, member of the European Parliament, Petra Bayer, president of European Parliamentary Forum for Sexual and Reproductive Rights. We'll have Giovanna Lauro, Vice President of Programs and Research at Promundo, and Carolyn Hickson, Regional Director of International Planned Parenthood Federation. You can drop your questions at the events platform if you want them to be answered by our panelists at the end of the discussion later. And our session will be opened by a presentation by Marusha Gottner, Head of Operations Unit, EIKE. Gottner, the floor is yours.
Welcome to the session where we will focus on the implications of gender inequalities for one particular but imperative aspect of health. This is sexual and reproductive health and rights. The areas of contraception, prevention of sexually transmitted infections and diseases, abortion and maternal health will be in our specific interest today. I will also address the ways by which the ongoing COVID-19 pandemic may have affected access to care and services in this area. It is crucial to keep in mind that sexual and reproductive health and rights are basic human rights of key importance to women's and girls' empowerment and achievement of gender equality. Already, a biological sex determines to what extent an individual can access sexual and reproductive health care and services. For example, regarding gynecological conditions like endometriosis or specific diseases like breast or prostate cancer. Still, sexual and reproductive health and rights are shaped and structured around the societal gender norms and patriarchal notions about women's and men's roles in private and public sphere. All these may strip them, women and men, of their ability to satisfy their needs for appropriate sexual and reproductive health and rights. Only available, accessible, and quality sexual and reproductive health care and services can ensure women as well as men freedom to decide about their bodies, reproduction, and lives. And women and men are not only characterized by their sex and gender, they are not a homogeneous group. But are also determined by age, ethnicity, sexuality, social background, geographical location, family status, access to information, and ability to use it. So where possible, we will explore today the intersecting inequalities. What we will be talking about today. So what are sexual and reproductive health and rights? The UNFPA, United Nations Sexual and Reproductive Health Agency, defines that good sexual and reproductive health is a state of complete physical, mental, and social well-being in all matters relating to the reproductive system. It implies that people are able to have a satisfying and safe sex life, the capability to reproduce, and the freedom to decide if, when, and how often to do so. No need to say that this should be equally valid for women and men, and as already said, SRHR is a bedrock of gender equality. It is important to underline that investing in accessible and quality sexual and reproductive health translates to better public health. The ongoing COVID-19 pandemic has put public health systems under pressure, and SRHR services have also suffered, ultimately hurting women's bodily autonomy and welfare. On the positive side, the circumstances brought about by the pandemic have also led to ambitious responses to ensure continuity or even improved access to certain SRHR services. I will come back to the examples later in the presentation. And in the continuation, I will reflect on 4 specific areas: contraception, sexually transmitted infections and diseases, abortion, and maternal health. Let's go first to contraception. At a first glance, we can see that on average, 95% of women in the EU can meet their need for family planning and reproductive choices. But looking more into details, there are visible disparities between the member states and also between different groups of women. On average, 59% of the European women use one of the contraceptive methods, but we lack the data about the satisfaction with the contraceptive choices and also difficulties in the accessibility. For example, Roma women often experience barriers to effective contraceptive use. For example, for many, the contraception is either too expensive, getting it requires long travels. The services also lack attention to special needs of women who experience multiple discrimination. And like in other areas regarding SRHR, there is a lack of data on men's contraceptive uptake and their reproductive choices. Not collecting and having the data on men reduces the possibilities to holistically examine and introduce gender-sensitive approaches to SRHR. Let's have a bit closer look to the accessibility, availability, and affordability of contraception. Important disparities exist among the EU member states. Only 7 member states are ranking high on the European Contraception Atlas, which assesses, for example, contraception policies in place, accessibility of educational material, costs, and availability of emergency contraception. Evidently, there is room for improvement in the EU. Young people are more disadvantaged in the access to contraception. 1/4 of sexually active adolescents in the EU reports not using any type of contraception during the last intercourse, and adolescent girls were even more likely to omit contraceptives during the last intercourse. The pandemic has disrupted access to contraception for many women due to changes in opening hours or even closures of clinics, also fear of COVID infection, stock shortages, movement restriction, postponement of appointments for, let's say, long-term contraception, but also due to loss of income. The European Parliamentary Forum for Sexual and Reproductive Rights has highlighted that existing challenges to access have aggravated during the pandemic, especially for groups of women already at risk of unmet needs, such as young women, women with disabilities, women in rural areas, and refugee women. And in response, many EU countries have reacted with measures to improve access, just to name a few initiatives. For example, minors between age of 16 and 18 were allowed to buy morning after pill. Telemedicine and remote consultations on contraception were introduced. Prescriptions were posted by mail or directly into pharmacies. The next focus are sexually transmitted infections and diseases. Sexually transmitted infections are a steadily growing public health concern in the EU, which is constantly addressed by our colleagues from European Centre for Disease Prevention and Control and WHO Europe. While an easy access to barrier contraceptive methods, such as condoms, is one factor that inhibits the transmission of STIs, there are also other steps to take. Safer sex habits, testing and tracing are essential to stop STIs from spreading. However, women and men, and especially girls and boys, face gendered social stigma and risk unawareness, which may result in avoiding the testing. For example, harmful stereotypes of masculinity might discourage men from taking care of their sexual health and STI risk prevention. Another example, social norms restricting female sexuality introduce stigma to young women to get tested for chlamydia, even though they are the group which has the highest share of infections. Again, an intersectional perspective is needed to understand sex behaviors and reluctance to testing of different groups of women and men. Only then the prevention and intervention policies can be efficiently applied. Next focus is access to abortion. Abortion is the area where the intersection between sexual and reproductive health and rights is the most visible. The circumstances under which an abortion is considered safe, meaning without the risk of criminal or legal sanctions, stigmatization or stress, directly influence the health of women and girls who need an abortion. And it's about their physical and mental health. Currently, abortion is banned in one EU member state. All other member states allow it when certain conditions are met. And these conditions or barriers vary from low to high across the EU. The highest barriers to abortion are declaring it illegal or severely restricting the circumstances under which it is legal. And the common barriers to safe abortion include mandatory waiting periods and counseling, parental consent, and consensuous objection of medical staff. We can see the situation in member states on the slide. And these barriers are even higher for women who belong to disadvantaged groups such as adolescent girls, undocumented migrants, or women who experience intimate partner violence. The obstacles have even increased during the COVID-19 pandemic. It is also important to note that restrictive abortion policies do not amount to fewer abortions or higher fertility or better maternal care. They lead to women and girls searching for alternative solutions outside the healthcare system, not necessarily being safe. Few words on pregnancy and maternal health. Although the EU does well in international comparisons regarding maternal mortality and adolescent pregnancies, further improvements are still needed in these key areas of sexual and reproductive health and rights. Young women and girls carry greater health risks, both physical and mental, when they become pregnant and young mothers. In addition, they have difficulties in pursuing education and achieving economic independence. And as mentioned before, 1/4 of EU adolescents reports not using contraception during the last intercourse. On the graph, you can see that in the EU, out of 1,000 adolescent girls, 11 have given birth. There are big differences between the member states. Those with the highest shares of adolescent births are also the ones where sexuality education is not compulsory. And just a few words on maternal care and mortality. You will find much more information in our index report. Unsafe abortion procedures and negligent post-abortion care are not the only factors putting women's lives at risk in relation to pregnancy. Maternal mortality and care inequalities are higher among certain disadvantaged groups like women with disabilities, Roma women, undocumented migrant women. For example, only 11 member states have policies regulating the access to maternal health care for undocumented migrants. And I would like to conclude with a few takeaway points. In order to enable future research and resulting public health interventions in the area of SRHR, we need complete sex-disaggregated data. This concerns especially closing the data gaps for boys and men. Another point, young people, especially young women and girls, have been identified as particularly vulnerable. Comprehensive sexuality education from early age and easy access to contraception can help prevent adolescent pregnancies, inform girls and boys, women and men about their rights, prevent sexual and intimate partner violence, and maintain good sexual and reproductive health. Access to abortion is a transnational issue. If women and girls cannot access emergency contraception and abortion services in their home country, an unwanted pregnancy will pressure them to find it elsewhere in the EU. This oftentimes means semi-legally or under threat of their human dignity and health. The access to safe abortion means ensuring a comprehensive SRHR for women and girls. As we touched upon earlier, countries have revised some of their rules about service provision to respond to barriers arising from the COVID pandemic. With the pandemic subsiding in several countries, the restoration of services is an opportunity to rethink the provision and to make some of the improvements made in response to the pandemic permanent. This would be an important step in reducing obstacles to access SRHR care and services, especially for disadvantaged groups. I thank you very much for your attention, and I will follow the following panel discussion with great interest.
And now time is for our discussion, and let me introduce and welcome our panelists. Predrag Fred Matic, MP and DP Rapporteur on the situation of sexual and reproductive health and rights in the EU. Welcome. Petra Bayer, President of European Parliamentary Forum for Sexual and Reproductive Rights and very active women rights advocate. Hi. Giovanna Lauro, Vice President of Programs and Research at Promundo. Welcome. And Carolyn Hickson represents civil society. She's the Regional Director of International Planned Parenthood Federation European Network. Welcome and thank you for joining us. Mr. Matic, let's start with you. Could you, from your perspective as an rapporteur, reflect on what main issues and challenges we can observe in member states concerning sexual and reproductive health issues?
Thank you. Dear colleagues, first of all, I would like to thank you for organizing this event and for inviting me to participate. And of course, thank Marusha for the great presentation. It is truly a pleasure to be here alongside the experts and present the new Gender Equality Index and focus a bit more on sexual and reproductive health and rights. As some of you may know, SRHR has been my main topic in the last 2 years of my work in the Parliament, and I can proudly say that my resolution on sexual reproductive health and rights was voted in June this year in the European Parliament. That resolution marks a new era of the approach to this issue, but it has also showed large gaps in the member states. Overall, the main challenge is the backlash present against SRHR. That was emphasized through the pandemic, and it is clear that some are unfortunately hit more than others, with women and girls being at the forefront of the unequal distribution of burden. Not only are women leading the fight against COVID-19 in the health and social sector, but they are also being stripped of their sexual and reproductive health and rights on the daily basis. We see some European governments using the pandemic as a pretext to limit or ban access to sexual reproductive health and rights, and we in the Parliament have addressed this many times. Banning abortion care, limiting access to contraception, dealing with the problems in the supply chains for sexual reproductive health goods and services, menstrual poverty on the rise, and an enormous backsliding in all SRHR related issues is only part of the problems women are faced with. That is also viewable in the results we are discussing today, and those decisions contribute to the fact that we are very far away from achieving gender equality.
Thank you, Mr. Matic. Ms. Meyer, in what ways COVID-19 highlighted SRH as essential to health?
I think the main highlight for me was that it is clear that it is a human right that you can always make an informed decision about the number and the spacing of your children. And this must not be disrupted or diminished by a pandemic. The European Parliamentary Forum on Sexual and Reproductive Rights recently published a report how COVID-19 impacted and still impacts access to contraception by women. And quite soon, when we started with the investigation, it became clear that it is very hard to find sources on that, because really no European country has comprehensively and systematically monitored access to modern contraceptives during the pandemic. And that, of course, is not in line, as we already heard at the beginning, it is not in line with the recommendation of the WHO that says that sexual and reproductive health is an integrated part of access to basic health services. So if SRHR is not available, even in times of crisis, then we cut people from accessing their fundamental human rights. And that was, I think, a very important lesson we learned during the pandemic, that we really have to work on that access to sexual and reproductive fundamental human rights also have to be performed during pandemics and times of crisis.
Thank you. Ms. Hickson, how the assumptions or stereotypes of masculinity and femininity can impact the access or quality of SRHR?
I think the question is spot on. But first of all, I just want to say how much we welcome the index, and particularly the focus on sexual and reproductive health and rights, because it's never been more needed to acknowledge that they are the bedrock of gender equality, as the first speaker said. And Fred mentioned the backlash. We have movements right here in the EU whose sole purpose is to roll back gender equality and women's rights. And they start with reproductive rights. And it's exactly those stereotypes of men and women's role in the world that are the heart of what they want to achieve. They talk about a natural order where you have two genders, men and women, and where women maintain their fixed place in society, caring for the home, and providing the state with enough children to ensure that the power of the straight white male elite is not threatened. I mean, we see this happening in countries like Poland, most obviously, but even in countries in Europe, which might consider themselves otherwise champions of gender equality, their laws and practices on women's healthcare actually demonstrate the opposite and show how deep those stereotypes and that discrimination runs. Women, somehow, we're not considered capable of making our own decisions on our healthcare. If we do not want to go through a pregnancy, somehow it becomes the business of the state. And we're imposed with mandatory waiting periods, mandatory counseling, extra trips to the hospital, additional input from other healthcare providers. I'm a big fan of musicals, and there's a line from Fiddler on the Roof, which is given in the mouth of a Russian girl in the 19th century. And she says, well, you know, women just can't decide these things for themselves. Well, plus ça change. And that is one of the reasons underpinning why our access to reproductive health care is just not good enough. And for certain women, it's even more. In many countries, if you're poor, if you're at the mercy of laws that privilege a doctor's personal private beliefs over their patients' healthcare, if you're a migrant, if you're young, if you come from a certain region, what happens? You're either forced into continuing a pregnancy against your consent, or you're forced onto a plane or a boat or a train, or you're forced into risking your health and safety. And the biggest common denominator of all is that you are a person who was born with a uterus. That's discrimination. But I find it amazingly exciting that women, especially young women, are standing up so strongly for their reproductive rights right now, and to see so much changing in countries like my own country, Ireland. Because if you can't control what happens to your body, you can't control very much at all. So as Marusha put it, and as Commissioner Daly put it, sexual and reproductive health and rights are at the heart of gender equality. And the EU needs to use all the tools at its disposal to continue to achieve progress, to avoid retrogression. And yes, that does have to include tackling gender stereotypes and harmful gender norms from the very earliest age, because they do lie at the heart of lack of access to sexual and reproductive health and rights.
Thank you, Ms. Laura. We saw the upsurge in gender-based violence in child marriages in adolescent pregnancy. If, as we see, COVID-19 has the face of women, why should we talk about men?
Yeah, thank you so much, Raza, for this question, and thanks the organizers also for being here with you all today. It's 6:30 a.m. where I am, so it's a pleasure actually to be on such an energizing panel. It's waking me up very nicely. So why should we talk about men? For two reasons. First of all, because inherently the pandemic has had harmful consequences on men, but also because the consequences on men are often also shouldered by women and girls and impact their lives as well. As we know, there is evidence that in many states in the EU, for instance, men have experienced higher mortality rates due to COVID. This is due probably to some biological factors, but also very importantly to harmful notions of masculinity. We heard earlier on our colleague Marusha Gortnar talking about that, how men are raised to be overly self-reliant to a point of excess, not seeking healthcare until it's too late. And that definitely can have an impact, of course, on a disease like COVID. And at the same time, when men get sick, we know evidence tells us that usually it's women and girls who take the responsibility of looking after sick relatives. And so that also links to another core element of gender inequality, which is the unequal distribution of unpaid care work at home, which influences the time that is left for women and girls to access many other services, including sexual reproductive health services. If we look at the data available, for instance, around time use, in Europe, the most recent, I think it's from 2016, so quite outdated now. But we still saw in 2016 that about 80% of women in the European Union spent at least 1 hour a day in domestic work, which is one of the dimensions of unpaid care work, while for men, the percentage was 30%. So it's a massive divide, which has obviously worsened during the pandemic, as we all know. And at the pace that we saw in 2016, we already knew that we would achieve gender equality in unpaid care work between men and women only in about 100 years at that pace of change. Given that things have worsened, this really screams as an emergency now amongst one of the consequences of why during the pandemic and after the pandemic, we should work with men to change the ways in which they behave around unpaid care work. For those interested, there is a global campaign on this topic called the Men Care Campaign that really aims at engaging men as equitable caregivers, changing the ways in which they interact with children, but also changing the time they spend in domestic work, looking for sick or disabled relatives. And Promundo and other organizations are behind this campaign in over 50 countries globally. And then one last remark, actually, I'm talking a lot about men and women, but I don't want to reinforce only heteronormative notions of society. We know that the pandemic has had also a disproportionate impact on LGBTQI individuals that are often either more hesitant to access health services or have been impacted by the reduction of health services, sexual reproductive health services during the pandemic. So I just wanted to note that, because I'll be talking a lot about men and women, but we're also talking about individuals of all gender identities. Thank you.
Ms. Laura, would you say that comprehensive sexuality education is the key to challenge those harmful gender norms and let us advance to gender equality?
Comprehensive sexuality education is definitely an essential tool to advance gender equality, especially because we know that in order to change the ways in which men behave, we need to start early, as soon as possible, as young as when boys are 3-4-year-old. And so investing in primary prevention by working in schools and community centers, or working with sports where boys are first socialized, and of course also working with families, is an essential starting point. And comprehensive sexuality education, of course, it is within this context, talking about sex not only as something associated to diseases, but also talking about the positive aspect of sexuality with boys and with girls, because we know that the ways in which children are raised around sexuality start to diverge very significantly already when children are as young as a 7-year-old. And so encouraging boys to look at girls, thinking about agency and consent and issues related to safe sex, and simultaneously working with girls to strengthen their sense of agency and self-esteem, it is crucial as a way to foster primary prevention services throughout the educational system, starting again from a very young age. Often we think about this as something associated with adolescence, and of course it is a crucial service to provide to adolescents, but we know that it's just as important to start with very young adolescents and even with children. Of course, the way we talk about these topics change, but the content needs to be there, and the intention to change the ways in which we raise our children needs to be there. Thank you.
Ms. Hickson, would you agree with Ms. Lauro, and do also boys and girls should receive this education equally?
Absolutely, 100%. But, I'm now a 55-year-old woman, and I think that we need to hear it directly from young people themselves, what they need. So I'm really pleased. I'm sorry that Luisa wasn't able to be with us today, but we do have a brief video of one of our member association young people talking about the work they do in CSE, specifically around gender norms consent. So if I could ask you to play that.
Hi, my name is Louisa. I come from the Latvian Association of Family Planning and Sexual Health called Paparazziets, and today I'm going to tell you why it's so important to educate young people on gender-based violence, consent, and so on. So sex education definitely goes beyond just information on biology, and a very important aspect of sex education is how it can be used to prevent violence and other related things, because it can give young people the skills to recognize and address abuse and to protect themselves from certain situations. For instance, relationship and sexuality education helps prevent intimate partner violence by equipping young people with the skills needed to question harmful behaviors that might otherwise be seen as normal. Or, for example, knowing how to identify possessive and controlling behavior in a relationship and having the confidence to assert oneself and to ask for support is key in preventing violence. And if young people aren't supported in questioning these behaviors, they might accept them as normal even though they could be very harmful. Or when a young person is taught that saying no is a full sentence and that they don't need to engage in anything that they don't want to engage in, that gives them the support and the confidence to know that it's okay to to stand up for yourself, and that it's okay to not do something that you're not comfortable with, even if it might upset someone else. Or in juxtaposition, how can a young person know what consent is if they're never told about the lines that you can't cross? Because without this information, there might be people that think that it's okay to push someone over their boundaries or to make someone do something that they don't want to do just because of one's whims. And there are many young people that don't get this education throughout their lives. And from situations like these, there arise many problems that could have been prevented by giving the young people the information that they would have needed. Because where else would young people get the knowledge that they need? Because not everyone's parents talk to their kids about this stuff. I, for instance, was very lucky because I got this information from my parents, from my teachers, from my friends' parents, and I grew up with people surrounded by this information, and some people can also be not as lucky as I was, because even if they're educated on these topics, they could come in with contact with someone that isn't, and that might cause a very unpleasant situation, or even worse.
So I think Louisa said it much better than I could, but it's also important to recognize that we actually have evidence that when we take sex education out of the purely biological stall, it does actually have real impact on addressing harmful gender norms and protecting young people from gender-based violence and discrimination. This year there was a publication by UNFPA and BZGA, and it showed that programs, CSE programs which address gender rights and power, are up to 5 times more effective in reducing negative outcomes, including unintended pregnancy and reducing STIs. And there's a lot of that kind of research in different countries, in Mexico, in Portugal, etc. And we really need to be listening to that and doing more, because we actually have the tools and we have evidence of their effectiveness, but we're not using them. A lot of member states do have mandatory sex education, but it's just too little, too late, too biological. And you know, the one thing that really shocked me about the report today was the statistic, and they had it in the executive summary, was that 25%, that's 1/4 of the young women interviewed between 16 and 29 had experienced online abuse. Also by social media. And I wonder if you reduce the age group limit, that figure would probably increase. We've seen how much violence, domestic violence, increased during lockdown. And I'm really asking, if 1/4 of young women right now are experiencing social media abuse to that extent, do we really think we're moving the dial for the next generation of women and people of all gender identities who are targeted by perpetrators of SGBV? I don't think we are. I think we're failing, and I think we're failing young people. Of course, we have to prevent and support young people to prevent unintended pregnancy and protect from the disease, but this is the treatment of the symptoms. We need a vaccine against gender-based violence and discrimination because it is a pandemic. Every member state should be including gender transformative CSE in their mandatory school curriculums, and we should be ramping up research in schools, action research, so that we do gather and have more and more data showing us what really works. CSE is a vital ingredient in the prevention of SGBV, and as such, we do really hope that we will see it in the prevention pillar of the EU directive on SGBV. So I'm really, really pleased that we could hear directly from a young person. They're speaking up on so many issues across the world. It's their world more now than it's my world. So let us listen to them and let us act, because they need us to act. Thanks.
Ms. Mayer, would you agree with Ms. Hickson that abortion is the consequence and the education is the prevention, or, as she said, the vaccine of this problem?
I think we have very good evidence in Finland, where there was a high teenage pregnancy numbers in the 1970s. And then when sexuality education was introduced to schools, it clearly fell down. And then due to budgetary restrictions, they had to cancel education, sexuality education at school, and it increased again 2 years later. So first of all, it is clear that there is a totally strong, it's evidence that there is a connection between the both. And yes, of course, it also shows that in these countries where you have good sexuality education, where you have good access to contraception, even the abortion rates are lower. And in those countries where abortion is banned, is legally forbidden, you still have abortions, but they are driven underground. That means they are less secure for women and they are more expensive. Or women have to go to other countries, as it was already mentioned, but it's only those who can afford that really have the money for it. And those who have not the money to go to a different country simply seek unsafe abortion. And we know how risky it is for a mother and probably also for the baby she will get nevertheless.
COVID-19 pandemic brought many restrictions, and Ms. Bayer, how those restrictions affected the ability, access to contraception?
Yeah, in the report of the European Parliamentary Forum, we found 5 main barriers to contraceptives. First of all, it was the users' fear of COVID-19, especially in the beginning, where they really respected all restrictions, for instance, confinements that were in place, and also had an aversion to becoming an extra burden to the health system. So they better stayed at home and didn't seek for advice or help, which is both the case for abortion and also the access to contraceptives where you need interactive measures like for long-acting reversible contraceptives, which are not easily can be prescribed like a pill you get at the pharmacy, but you really need someone to put it on the right place in your body. The second barrier was that clinic and opening hours were reduced or even locked down at all. Also a problem for both contraceptives and abortions, because you cannot simply postpone it. You cannot postpone an abortion to 2 months later, and you cannot postpone to have access to a contraceptive for some time because you need it probably every day. The third reason was a lack of clear communication. Many women, for instance, were said earlier that it's very important to be very strict on timing when, for instance, to have removed these long-acting reversible contraceptives, and suddenly it was said, okay, keep them longer, no problem at all. So they were a little bit confused about what's the clear message now to me. So lack of communication was really a great problem. And it was also a fact that there were stockouts in pharmacies. On the one hand, because of the disruption of the supply chain, and it became so evident that the European Union is very dependent on other countries, even when it comes to non-high technical products like condoms, which were not available for some times. And the last barrier, of course, was and it still is, and it was also before and will be after that, a financial barrier, especially during COVID-19. People lost their jobs, so they had less income, and because of the shortage, also the prices for devices and contraception increased because of a shortage, and so there was a huge financial barrier. In this way, or in this occasion, I think COVID-19 acted more or less as a magnifying glass to those who were in need or had unmet need to contraceptions even before. It were mentioned, migrants, young people from marginalized groups, from Roma, undocumented refugees, and people like that.
Mr. Matic, would you say that SRHR is important for the overall gender equality?
It is undeniable that sexual reproductive health and rights are intrinsically linked to the achievement of gender equality overall. No discussion on an equal European Union can be done without highlighting that the access to sexual reproductive health services and healthcare are crucial for achieving a society where gender equality is fully implemented. Without that, and ensuring that no women and girls are left behind in their right to access sexual and reproductive healthcare, gender equality will not be achieved. I have said many times in the last months and will continue to do so until every woman in the Union can freely decide about her own body and have her bodily autonomy respected, gender equality is from behind being achieved. We have to shed light on the fact that half of EU population is not only faced with the pandemic, but their freedom to make their own decision is constantly under attack. That is a deploring situation, one which we all must work to correct without delay before we can even begin to say we are reaching gender equality.
Mr. Matic, to end this our panel with a brighter note, what are the main challenges that awaits member states in the future? What are those?
The main issue we see is the argument of national competence when it comes to discussing health and sexual reproductive health and rights. Yes, we absolutely agree that member states have to decide on their own health legislation. But I ask you, what we do when the legislation denies access to healthcare and limits the possibility for medical services? We need to find a balance in this in the future and see how we deal with the member states who constantly deny access to sexual reproductive health and rights, thus also impeding the achievement of gender equality. I only see one option here, a clear and strong reaction by all three institutions, Parliament, Commission and Council. And my hope is that the index and its numbers and data, as well as the findings of the overall context, can and will entice the adequate response from the Commission and the Council, as the Parliament has made repeated calls for that, including also my resolution on sexual and reproductive health and rights. I use this opportunity to once again thank the AGE team for their work in the index and ask for your support to all of us in the Parliament fighting for gender equality, namely also to demanding universal access to sexual reproductive health and rights.
Asmar, what would be your recommendations for the future?
To take SRHR serious, to really see it as an integral part of health services, and in particular, really to guarantee access to contraception and choice through national healthcare services plans and budgets always, and even in times of pandemic. Then also make clear that modern methods of contraceptives is defined as an essential healthcare service that has to be delivered and reimbursed by public funds all the time. I think it's important to include the availability of healthcare professionals in policies as an essential health service delivery. We also have to strengthen primary health care organization and really fund them. That they really can offer their services in under any precondition. It is important to identify and track gaps to universal access to contraceptives and have a comprehensive and monitoring and evaluation, and especially focus on underserved groups and how they could more easily find access. Then it's also important to not forget, and we had it in the video already, that adolescent and young people have access to contraception and to information they need, and that they have counterparts they can debate about it with. It's important to continue sexual and reproductive health care and counseling also via telemedicine, how many countries started with that during the crisis. I think we should really keep that as an ordinary, usual way how to interact with patients, if wherever possible. Then I also think that communication and information are very central. It has to be one clear message. People have to know where they can go, when they can go where, and what they expect. And in this regard, it's also very important to encourage people to seek care and counseling even in times of crisis. It was also very obvious. We have clear figures that, for instance, breast cancer care was totally diminished during these months of the pandemic, and that's of course a very bad impact to women's health. And last but not least, that we really built upon the lessons learned from the COVID-19 pandemic, and to develop and integrate innovative solutions to sustain and expand access to contraceptions and choices of methods. And that also goes together, for instance, new forms like online comprehensive sexuality educations and other things. So there are a lot of takeaways that can improve the situation even after the pandemic, I'm sure.
Thank you. Ms. Hickson, Ms. Meyer mentioned telemedicine. What are other interventions that could carry on after the pandemic and that were successful during it?
One of the things that I think it brought home was just how important it is to have strong civil society organizations working and advocating for SRHR, and the importance of ensuring that they are supported and sustained. Because when many governments fail to include SRHR as an essential service, and Petra's already mentioned that, you can't put off an abortion for a couple of months, or, take a contraceptive 3 weeks after the fact. And a lot of governments didn't include these as essential services, and it left childbirth procedures disrupted. People had difficulties accessing HIV treatment and testing, suspension of abortion care. And it was actually local civil society. It's always, in any emergency, it's always the local organizations who respond first and know what to do. And they got off the blocks and they advocated with their governments, and they got that changed. For example, in Ireland, it was the Irish Family Planning Association who worked with their government, and they were one of the first to bring in telemedicine and self-care for abortion, as Petra mentioned, and that was followed by countries like France, and no longer an EU member, but the UK, and so on and so forth. So we need to make sure, as Petra said, that we don't go backwards, and that telemedicine is continued for abortion. Quality feedback from the IFPA showed that women actually welcomed it, felt supported, could manage it, although we also need to ensure we do maintain the options for in-person clinics so that women have the choice that they deserve. Finally, I've talked a lot about CSE, and Petra also mentioned the CSE going online. We learned a lot during the pandemic, both from the technical perspective of how to make CSE online interesting and fun, exciting. Kids would want to participate, but also we had to work hard to ensure that it was a safe space digitally, and that was free of risks of cyberbullying or gender-based violence, and where young people's privacy is protected. We learned a lot, and we've had examples of where we really expanded access. Estonia was one of those. They actually quadrupled the numbers of people attending their sexuality education between April and December 2020. So we need to build on those lessons. It's a fantastic opportunity to start ramping up the CSE approach that I was talking about, and try and start increasing the vaccination campaign against SGBV and protect those who are targets of bullies.
We have a question. In the index report, Taiga mentions that the access to sexuality education varies across the countries. And Ms. Hickson, would you say that there is any standard approach to sexual education that countries could benefit from? You mentioned Estonia's example. Could Estonia be the flagman of
There
these
are,
changes?
there are many examples, but I mean, there are CSE standards developed by UNESCO. So the standards are there, but I think the practice is really interesting. And I think key to all of this is enabling those country examples to come together and discuss and look at what is working and take the best practice from one country to another. But also, as I said, I think we need to ramp up the research and really invest in this, because I think it's an incredibly important opportunity to move the dial for those young people.
Ms. Laura, what long-term change will COVID-19 bring to, in terms of gender equality, gender relations, and how we can minimize that negative impact that arose?
Yeah, thank you, Raz. I mean, we are seeing, of course, how COVID is exacerbating pre-existing issues such as the pandemic of violence. And we're also seeing how there are some very small promising changes. We see, for instance, the men, at least from studies available, the men are increasing the time spent in unpaid care work. But we also know that this comes at the same time where women's time spent in unpaid care work has increased even more. So definitely much more is needed. So what can we do? I would say maybe 5 core recommendations that I wanted to share with you all today. The first one builds on what Mrs. Gortner already mentioned about the importance of collecting sex disaggregated data. And I would push it even further in terms of really collecting data that is disaggregated across multiple intersectional identities, whether it's gender identity, issues related to employment, education, location, race and ethnicity. All of this is crucial to ensure that we base our actions on evidence. It's crucial to ensure that we measure the progress of our action, and it's crucial for civil society to keep governments accountable on their promises. So that's the very first, very important element that I would recommend. The second element is focused maybe more around policies. That is, a lot of the changes that we want to see when it comes to gender equality and sexual reproductive health and rights as related to gender equality are very often portrayed as related to individuals. And actually, we also need to think, of course, about systems and what can governments do for gender equality. In terms of policies, the first element that, of course, we know works from evidence in several countries is ensuring that women and men and individuals of all gender identities have access to fully paid, non-transferable, equitable parental leave. We know that this really means the possibility of changing the dynamics in households and how this affects gender equality more broadly, including, for instance, communications around family planning, about sexual reproductive health choices. The other piece, very important in a moment of deep economic crisis related to the pandemic, is also around cash transfers and other measures of social protection. As we plan such measures, let's make sure that we keep a gender equitable lens. Let's make sure that measures that can help get families out of poverty do not actually end up reinforcing harmful gender stereotypes by, for instance, imposing an inequitable burden on women by requesting certain conditionalities related to children's health or children's education that often fall on the shoulders of women and girls in the family. So thinking about how we design policies is crucial. The third element, of course, within this context is also concerns primary prevention. Let's keep on investing in primary prevention. Comprehensive sexuality education, of course, it's a part of that, but really thinking about the ways in which we raise our boys into men is going to make a massive difference in the future in terms of gender equality across multiple dimensions. sexual reproductive health and rights being one, but also violence prevention being another one. We know, for instance, Mrs. Hickson was mentioning the uptake, the increase, of online abuse during the pandemic. And we know from evidence that young men who have internalized harmful notions of masculinities around the world are 10 times more likely to perpetrate online abuse. So we know that the ways in which we raise young boys means for how they will behave in the future. And then very finally, the last point is around secondary prevention, also the importance of working, of course, with perpetrators and working in partnership with women's rights organizations as we do this. I think as I talk about men and engaging men in the fight for gender equality, it is crucial to remember that we need to do so in ways that are feminist-centered. There are many ways to work with men. Not all of them are feminist-centered. And so let's increase the funding, let's keep on supporting women's rights organizations, and let's follow their lead in terms of what works to prevent violence, to promote gender equality, and to promote sexual reproductive health and rights for all. Thank you very much.
I want to thank all the panelists for your input and valuable ideas and expertise. We are really glad that you could be with us and share that expertise. And I would like to say that we are continuing the event from our studio in Brussels live with Jack, so feel free to switch. Thank you all.